So in this section, we'll be talking about renal failure for your test. We will cover both acute renal failure and chronic renal failure. Acute renal failure is the rapid loss of renal function due to damage to the kidneys. It is also known today as acute kidney injury. So this is that initial phase that you will see people in renal failure, except this is recoverable. So acute renal failure is not like chronic renal failure, which is progressive and degenerative. Acute renal failure, the initial injury, once it's discovered and has given a solution, there can be recovery to the renal function. A healthy adult eating a normal diet needs a minimum daily urine output of 400 mLs to just basically keep up with the body's waste products. So if it's less than this, it indicates a decrease in the glomerular filtration rate, which becomes very important when we determine which stage of kidney failure the patient may be in. So again, really we have to have more than 400 ml urine output just to keep up with our daily waste products. Pathophys, basically the underlying problem. There's always an underlying cause that you develop acute renal failure, such as hypovolemia, hypotension, reduced cardiac output and failure, and obstruction of the kidneys. So in any of these cases, there's decreased blood flow to the kidneys, decreased kidney function. If these progress, they can lead to kidney failure. Causes, so I do want you to remember this. There's pre-renal, intrarenal, and post-renal. So if I was to give you an example on the test of one of these, you could identify if it was pre-renal, intrarenal, or post-renal. An example of pre-renal are impaired cardiac efficiency, vasodilation, volume depletion. Intrarenal are like ischemia, nephrotoxic agents, the infection process, perhaps like a medication that's working on the nephrons. So anything that has to do with the renal system itself. Post-renal is an example is just an obstruction. So maybe a urinary tract obstruction like a stone, something like this. So realize it's in three parts: pre-renal, intrarenal, and post-renal. There are 4 phases. The initiation phase is a period when the initial insult to the kidneys has occurred. It ends when oliguria develops, and oliguria is that decreased urine output. It also accompanies the increase in the serum concentration of substances excreted by the kidneys. Then we move on to the diuresis phase. This is the period that marks by gradual increase in urine output. So the oliguria period would be the less than 400 mLs output per day. That would indicate that we couldn't keep up with our own waste products. The diuresis is the next phase, and it's a recovery phase, so you would see that you would have an increased urine output. That basically means your GFR has started to recover and you're increasing your output. The recovery period includes the improvement of renal function and may take up to 3 to 12 months, depending on what type of injury and how long that injury existed. Clinical manifestations, basically this affects every body system. As we know, especially in older adults, we may see lethargy or the impact on the central nervous system. They may be more drowsy, a headache, they may be unable to focus. It can also produce seizure-like activity. These people usually have dry mucous membranes from dehydration. The creatinine, again, is a lab that we measure. All phases of acute renal function exhibit an increase in creatinine. It is the most sensitive test to our renal function. Now don't get this confused because creatinine is the most sensitive, but the glomerular filtration rate is what we base the stage of renal failure on. So understand really the three main blood labs that you look at are glomerular filtration rate, creatinine, and BUN. So these are the three labs that you most need to be most familiar with in talking about urine function. Also, I would know the specific gravity. So understand when and what numbers it would look like if it was more concentrated or if it was more diluted. Prevention from renal shutdown or acute renal function problems are hydration. Make sure that the patient is fully hydrated. Prevent shock. Close monitoring between blood pressures and input and output. Blood administration to make sure that they are avoiding any severe transfusion reactions that would shut down their kidneys. Infections, again, to make sure they're not becoming septic to kind of put them in urosepsis, which would lead to maybe acute renal shutdown. And then toxic drug effects. This is really important in nursing. Oftentimes, this is pretty much in our realm of practice, and we need to pay attention. If our patient is not hydrated well enough, we really should not be giving them high potency medications like IV vancomycin. Even IV Toradol can really impact their kidney function if they are dehydrated. So please, please, anytime you're on the floor at clinical, make sure you're checking the hydration of your patient. If they are dehydrated and you're pulling out big meds like vancomycin or other antibiotics like diptomycin, you may want to consider consulting with a physician and making sure they are well hydrated before we do that. Because if we just give them a large dose of antibiotic without the proper hydration, we can really shut down their kidneys. And we also have to pay close attention anytime we're delivering any IV contrast, especially if they're diabetic. So realize this is pretty much a nursing realm because we see the patient every day. So if we think that they are dehydrated, we need to contact the physician and ask if he wants to give an IV bolus before maybe they deliver that specific antibiotic. Now, sometimes with renal patients, this is a fine balance because some of these patients can be dehydrated but fluid overloaded. So, of course, we wouldn't want to provide more fluid if that fluid is not going into the right spaces. Urine tests, let's talk about the 24-hour urine tests. So sometimes what they will do is actually take a blood test and they will compare the waste products in the blood to the waste products in a 24-hour urine test, or the BUN. In order to obtain this, they have to collect their urine for 24 hours. The first sample will be tossed, so their very first sample of their 24-hour collection will be tossed. Oftentimes in the instructions, they're asked to keep this in the refrigerator. So they will collect their urine for 24 hours, take it into the lab to be tested. Glomerular filtration rate we'll talk about later in the slides, but this helps determine what stage of kidney failure or renal failure the patient may be in. Also, the specific gravity measures how concentrated the urine sample is. A concentrated urine sample would have specific gravity over 1.030 or 1.040. Our nursing role, of course, is to monitor fluid and electrolyte balance, making sure the patient's not either fluid overloaded or dehydrated, reducing metabolic rate, so making sure they're resting, encouraging their fever or encouraging fluids, monitor any fever or infection. To prevent infection, this also includes good skin care, making sure that they are dry and clean. Making sure we're providing safety measures in case their CNS is impacted so they're not a fall risk, making sure they have easy access to the restroom if that's the role that they're in, and electrolyte balance especially, we want to keep track of the phosphorus, calcium, and really sodium and potassium levels. So make sure for this test you know the sodium and potassium levels for sure as well. Glomerular filtration rate determines the stage of renal disease. BUN and creatinine are labs that we absolutely monitor because BUN and creatinine are byproducts or waste products in the body. And if they increase, that means we are not excreting in our urine enough of those products to get rid of them from our body. The electrolyte levels, we do need to watch the acid-base balance, which you will have much more discussion in Child 1 about. But the electrolytes we want to pay special attention to is potassium. These patients are at risk for hyperkalemia. Decreased production of the active form of vitamin D can cause low levels of calcium in the blood. An inability to excrete phosphorus by failing kidneys can cause elevation in the blood to rise. So make sure that you keep track of these 3 electrolytes for sure. Also, many times these patients can become anemic as well. So they become very short of breath when they ambulate. So we need to watch for the signs and symptoms of anemia as well. As we move on, we're going to discuss chronic renal failure. This is really more insidious, more progressive than our acute renal failure. And of course, chronic renal failure, they do not recover from this. It is a progressive disease. Again, lots of different causes. Acute renal failure could be the cause of chronic renal failure, but again, those underlying conditions that cause acute renal failure to begin with. Chronic renal failure can also be caused by things like autoimmune disorders, things like lupus, nephrotoxic agents. You see a lot of this with drugs, certain kinds of drugs that they have to be on. Diabetes seems to be a progression of diabetes, chronic infections. So just kind of know the major reasons why a patient could develop chronic renal failure. Again, affects all body systems. The final stage of renal dysfunction is end-stage renal disease, and it is demonstrated by a glomerular filtration rate of less than 15 to 20%. I just remember 15%. Basically, renal failure is when the kidneys can no longer remove the body's metabolic waste products and they can't perform their regulatory functions, so something has to be done. And in this case, we usually will provide dialysis to these patients. Accumulation, as renal function declines, the end products of protein metabolism, BUN, creatinine, accumulate in the blood. Predisposing factors, diabetes is the most common in the United States, age older than 60. Like a congenital kidney disease, family history of kidney disease, autoimmune disorders like lupus, bladder outlet obstruction like BPH, and then sickle cell. So as we talk through the stages of renal function, I kind of divide these up into 30s, well, really 15s. So less than 15, I consider that severe end-stage kidney. This is when they would need to be or be on dialysis. So really anything less than 15 is dialysis. Then we go 15 to 30, and this is the severe reduced kidney function, okay? Then anywhere from 30 to 60 is a moderate reduced kidney function. 60 to 90 is mild reduced in kidney function. And 90 to 100, or some will even say 120, will be the normal kidney function. So if you kind of take it in 15s, 15, 30, 60, 90, and then 120, it makes sense and you can kind of remember it. I don't expect you to break down 3A and 3B. If you just go from end-stage renal disease, severe, moderate, mild, and normal, you'll be just fine. And here is just another slide that kind of breaks it down. It is 5 stages of chronic kidney disease. So complications, as we've discussed previously, are hyperkalemia due to the decreased excretion, metabolic acidosis, catabolism, and excess intake. But hyperkalemia is something that needs to be paid attention to. Hypertension may develop because of the sodium and water retention, anemia, as we discussed, bone disease, and pericarditis. Nursing assessments assess fluid status, so I and O become very important in these patients. And of course, assessing the lungs, see if they have crackles, see if they're wet, see if they're dry, see if they're dehydrated, see if you think the fluid is actually in the wrong place. Dietary patterns, so food intake, especially when it comes to electrolytes and anemias. Nutritional status, so any weight changes, laboratory values. Assess the underlying cause of the renal failure, and is it being treated? So we always have to treat or address the underlying causes of renal failure. Assess the patient and family responses and reactions to the illness. Do they understand kind of where the patient is in the process of the stage of chronic renal failure? And then no signs and symptoms of hyperkalemia. So if my patient had hyperkalemia, what signs and symptoms might they display? Discharge planning, of course, if they have vascular access, it's part of our scope to determine if they're going to need that on a regular basis. If they are, peripheral IV is probably not the best, and maybe we should suggest they get a midline or PIC before they are discharged, making sure if they are signed up for dialysis or consults for dialysis, make sure they understand how to follow up and who to follow up, making sure that they have home care referral as well, because this is a disease process that will be with them and the family for the duration. So this is not like acute renal failure where they can go home and recover anywhere between 3 to 12 months. That recovery period is usually complete. This does not have a complete recovery period. Pharmacology in chronic renal failure, we need to make sure that we are treating the calcium and phosphorus, so maybe prescribing any binders that they may need, any antihypertensives, any anti-seizure agents. Erythropoietin or Epigen is used to treat anemia associated with end-stage renal disease. This is oftentimes given in injection form and helps to produce more red blood cells, so it helps prevent that anemia from developing, or at least decreases it in its severity. Dietary nutritional therapy, how much intake, how much output, what are they eating? Are they eating things high in potassium? Are they eating things high in calcium that need to be decreased? And dialysis. Dialysis is usually started if they can't maintain a reasonable lifestyle with conservative treatment. And basically it's established if their glomerular filtration rate is less than 15. Signs and symptoms of fluid overload, you guys can look through these. I expect you to know them, and actually I bet you already do. 2 types of dialysis, hemodialysis and peritoneal dialysis. Hemodialysis is, of course, the blood, so we remove the blood from the body. It goes out into a machine where it is dialyzed by the dialyzer, basically cleaned, the waste products are removed, and then that blood is put back into the patient. This is done via fistula. Hemodialysis used for renal failure removes toxic waste products. This is through a artificial or semi-permeable membrane. Starting therapy depends on the client's symptoms. not on the creatinine clearance. The fistula is actually surgically placed in the patient's arm most frequently. This is the device that is accessed when they have dialysis. The nursing role for this, so if you're not a dialysis nurse, you really have two major roles when you're dealing with a fistula. First, can you hear bruise? So can you hear that bruise when you listen with the stethoscope lightly? And can you feel the thrill? So the thrill is that pulsation that you may feel when you're palpating it. You do not want to push too heavily on the fistula. You don't want to occlude it. You just gently want to put your fingers over it and follow it and feel for the thrill all down the line. This ensures that there is blood flow, and we don't want to aspirate blood. We don't want to use this arm for blood pressures or blood product. We pretty much stay away from this arm for any other reason, but our two nursing assessments are for bruise and for thrill. Again, we do want to assess the site, assess it for any infection if it's new, assess for that circulation, so that thrill and that bruise. No IV blood draws, no IVs, no lines in this arm, no blood pressures in this arm, and I have to tell you, you just really should stay away from a fistula arm altogether. So if they have a fistula or wherever they have their fistula, you really need to avoid working with that area in any way. You need to make sure they have a bracelet on, a sign outside the door so a CNA doesn't come in the middle of the night and accidentally take a blood pressure on that arm. It can occlude it, and that really is their lifeline. And you do not want to see an angry dialysis nurse coming in if you have messed up her fistula. Hemodialysis, pre-dialysis care, weight. So we need to get their weight. We often will call this pre-dialysis their dry weight. Well, their dry weight is after. Their pre is maybe when they're still full of their fluid and waste products. Vital signs for sure. Potassium level for sure. So anybody who has dialysis or is going to dialysis, these things need to be measured and assessed. Especially in a care home when you're sending somebody out, you might want to make sure that their potassium level is where it needs to be. During dialysis, we want to watch for hypotension, muscle cramping, nausea, vomiting, headache, itching. Much of this is just fluid related, muscle cramps. We may want to give normal saline. That replaces the sodium, so it decreases the cramping. Disequilibrium syndrome, we're going to talk about in the next slide. It's rare, but more life-threatening. Post-dialysis care, monitor blood pressure, report hypotension or hypertension, watch for bleeding. Check weight, compare weight loss, should be close to the fluid removal, which is the goal set during treatment. Document any unusual findings, assess the site for bruit and thrill, and give any missed medications. So pre-treatment, if you have a patient in the hospital and you know that they're going to be getting dialysis, you might want to consider or ask the physician if they want to hold their hypertensive medications, especially medications like beta blockers, which are metoprolol, those type of medications, anything that will really directly impact their blood pressure, need to be held until after dialysis. And then after dialysis, you can reassess the vitals and determine whether they need to be given that blood pressure medication. Dialysis disequilibrium syndrome. This is important because it's a fluid shift, and actually the fluid shift can move directly onto their brain and cause immediate concern. It can cause disorientation, fatigue, confusion, convulsions, coma. So it's the osmotic changes and the electrolyte changes that can occur either during dialysis or really right after dialysis. This just needs to be, the electrolytes need to be determined and proper fluid replacement needs to be determined which kind of fluid to hang to pull that fluid back off of the brain. So peritoneal dialysis is used when the patient's own peritoneal membrane is used as the semi-permeable dialysis membrane. So the solution is instilled through a catheter that's inserted into the patient's peritoneal cavity, and that solution sits there sometimes for hours, sometimes continuous, sometimes for minutes, depending on what kind of dialysis they're getting, and pulls the waste products. It's a highly concentrated dialysis solution, so it pulls the waste products from the body into the solution, and then the solution is drained off the body. So this we would actually use preferably before the hemodialysis. This is much more convenient, a lot less invasive, and we're using the natural body as the semi-permeable membrane. So just read through this and make sure you understand how peritoneal dialysis works. Understand in any dialysis too, the solution that we'll be instilling, whether it's hemo or peritoneal, will go in quickly. Hemodialysis usually in 15 minutes, sometimes peritoneal even quicker than that. So when we instill it, it goes in quickly, and then in this case, peritoneal would sit there for hours, and then be removed. Hemodialysis, of course, is run through the dialyzer. Here's just a picture. So you'll see you have a solution bag. It's infused. Sometimes they can do this when they're walking. Sometimes they'll have them sit down for 4 hours at a time. So depends exactly which kind of peritoneal dialysis. Remember, with this type, oftentimes kinks will develop, so you have to make sure that if it's draining sluggishly, to just check and make sure there's no kinks. Go ahead and turn the patient from side to side, and that should then make your solution actually drain fairly quickly. Again, the doctor's orders will tell you how long to leave the solution in, when to remove it, and which type of solution to use. Again, different types of peritoneal dialysis that can be continuous or ambulatory peritoneal can be instilled up to 4 to 8 hours. When it's time to drain, the bag is rolled and the fluid is drained, usually by gravity. Make sure vitals every 15 to 30 minutes. Assess for respiratory distress, pain, or comfort. Assess the dressing around the catheter exit. Monitor and describe dwell time, and assess blood glucose levels in patient who absorb glucose. So let's think back on what we've learned in this part. So make sure you know the causes of renal failure. So the intrarenal, perirenal, postrenal, the phases of renal failure and what occurs in each. So understand when I would have decreased urine output, increased urine output. Key laboratory findings in renal failure, so make sure you know the normal BUN, the normal creatinine. What would that go up or down in renal failure? And glomerular filtration rate, would that go up or down? And how is our end stage or stages of renal function based on glomerular filtration rate? We also understand that creatinine is more sensitive measurement to how our kidney function is. Electrolytes we should consider potassium, sodium, calcium, and phosphate or phosphorus. Signs and symptoms of renal failure. Make sure we understand the predisposing factors of chronic renal failure. And then our stages of renal failure. So the 5 stages, or in my case, if you want to base it with 15, 30, 60, 90, understand what relates to that and what we would call it, whether it is end stage, severe, moderate, mild, or none. Dialysis, make sure you understand the differences and what you need to assess for hemo and peritoneal dialysis. Make sure you understand pre, during, and post treatment or concerns with these patients. Make sure you understand key assessments for the fistula with nursing, the bruise and the thrill, and contraindications. So when will we not take the blood pressure? We would not draw blood. We would not start an IV on that arm. So these are the key kind of things that you need to know from this chapter.